All right, so today we are going to start with tuberculosis, and this is a pretty long lecture because there is quite a bit of pathophysiology, because pathophysiology is important to understand tuberculosis and the treatment of tuberculosis. So the title slide is showing you an Egyptian mummy, and I'm showing you this because it shows that tuberculosis was present thousands of years ago as well, and it has been there since many thousand years according to the estimates, right? So these are the learning objectives. We will briefly look at the prevalence of of mycobacteria. We will distinguish between the diagnostic tests used for tuberculosis. We will look at empiric therapy and recommendations for latent tuberculosis, which is not active tuberculosis. Differentiate between treating latent and active tuberculosis. Identify the common adverse effects associated with medications. You have done this in pharmacology as well, but this is going to be a revision or a review of what you have already done. Then develop a treatment plan and formulate a monitoring plan to look at the side effects or development of resistance or presence of resistance, okay, whatever it is. So this is the reading material that you can refer to. And we will go on to this slide, which shows you drug-resistant tuberculosis in India. And in India, there are some strains of mycobacterium that are resistant to all the first line and second line drugs. So there is no treatment for that, and patients obviously they do not survive if they get tuberculosis. And similarly, multi-drug resistant tuberculosis is found in Far Eastern countries like Cambodia and perhaps some other countries as well. So the mycobacterium was discovered in 1882 by Robert Koch. And at that time in United States and Europe, a lot of people were dying of tuberculosis, and they say 1 out of every 7 person was dying because of tuberculosis. It was known as the white plague. So tuberculosis is a communicable infectious disease caused by Mycobacterium tuberculosis. You already know that. There is a latent infection in which the bacteria are present in the body, but there are no symptoms, no active disease. Maybe they are not dividing or they are not causing the spread of the disease or any symptoms as it is written over here. Active disease is with symptoms and is progressive, and according to estimates, 10 million people have active disease, maybe more globally. Globally, 2 billion people are infected, which is 30% of world population, and they have latent infection, which means that they might not have active tuberculosis, but the bacteria are there inside their body, inside the macrophages or somewhere. And 1 million to 1.5 million die from tuberculosis each year, maybe in third world countries and in Africa, Latin America, in these places. And this shows you the incidence or prevalence of tuberculosis. You know, this, if you look over here, this very dark picture, I think it's over here. I don't know which country it is. This is Chile or something, I'm not sure. But you see this more than 500 per 100,000 population. That's in South Africa and some African countries, and some other countries, I can't see them. But if you look at 300 to 500 people, that's pretty common in Africa, and a little less in India and Pakistan, Afghanistan, far eastern countries, right? And Saudi Arabia, if you look over here, Saudi Arabia has a very low incidence of tuberculosis, just like USA, Australia, or some European countries. And this is the epidemiology. I've taken this slide from Dr. Thamir's slide. And this is the incidence over here, annual incidence rate. It shows maybe 16 out of every 100,000. But that is the incidence rate of tuberculosis. It is from 2000 to 2012. And you can see this is USA statistic, and you see that the trend is going downwards starting from 1993. The prevalence and incidence of, actually, this is showing incidence, which means new cases every year. That has been going down from 1993 until lately, okay? So the question is that in Saudi Arabia, people from which of the following countries are expected to have the highest risk of tuberculosis? So what do you think? Which country? Egypt, China, Saudi Arabia, or India? And maybe I have an answer, which is
From India.
yes, that is correct. From India, maybe there are other countries as well, but the highest incidence is from India, and it's a little bit it is a little bit concerning because of multi-drug resistant tuberculosis. But when people come here, they undergo medical examinations, and those people are excluded. Okay, right. So, human immunodeficiency virus, HIV, is the most important risk factor for active tuberculosis, especially among people 25 to 44 years, and that is in the USA, and in mostly we have statistics from the USA, right? HIV infected individual with latent tuberculosis infection is over 100 times more likely to develop active disease than an HIV seronegative patient. Okay, so HIV is a strong risk factor for active disease. Transmission is through droplet nuclei, which means coughing, and even when people are living in overcrowded places or in overcrowding living places, then even when they talk or shout or sneeze, the droplets go out of their mouth, and they can infect or lodge into the lungs of other people. So people ill with tuberculosis can infect up to 10 to 15 other people through close contact over the course of a year. And I will show you a slide over here in which I'll explain that how the droplets hang in the air. And I've shown you a few pictures. These are not the droplets, but what I'm trying to show you that certain particles like smoke particles or very small dust particles or pollen or things, they float in air because they are so light. They float in air for long distances, even for miles, like you must have seen in dust storms that the particles are there and they are flowing in air. So similarly, when a person sneezes, the particles that come out of his mouth are of different sizes. Some are large droplets that they fall just 1 to 3 feet away. There are smaller droplets that fall down 3 to 5 feet away, and then there are very small micro droplets that float in air for some time. For example, if there is a corridor and a person sneezes or coughs, most of his and he then goes away, and the next person comes in the next minute or after 2 minutes, the droplets will still be hanging in the air, and the person might inhale those droplets although nobody is there. All right, so the micro droplets, which are very, very small, um, they can hang in air for some time. Okay, and what this is showing you is that when a person coughs or sneezes, he must have something like a tissue paper or something to keep them or to prevent them from spreading into the atmosphere. Right, so pathophysiology, primary infection is initiated by alveolar implantation. So the droplet is there hanging in the air, and the person breathes it in. Now, most of the droplets, because of the path that they have to traverse, from the nose, it has to bend, and then it has to go into the trachea, and the trachea is dividing 23 times. And it's only after that that the droplet can reach the alveoli. So there is a very high likelihood that the droplet will be caught by the cilia. It will hit the walls of the airways and it will be caught by the cilia, right? But some droplets, particularly if they are in high concentration, they may be small enough, which is 1 to 5 micron or whatever. They may escape the ciliary epithelial cells. They may not come in contact because, the ciliary epithelial cells and the mucus secreting cells and the goblet cells, they are secreting mucus, and mucus is very sticky. And any particle that is flowing in the airways, if it comes in contact with the mucus, it will get stuck there. And then with the help of cilia, it will be moved out of the respiratory tract, okay, of the airways. So those few droplets, they might reach the alveoli and the organisms multiply and are ingested by pulmonary macrophages where they are killed, or sometimes, that I'll show you later on, the mycobacteria, due to certain mechanisms that it has, will not be killed, okay? They survive inside the macrophages and they remain dormant, they remain alive, they don't die. And that's what basically the problem is, because the macrophage, it knows that there is a mycobacterium inside it and it is not able to kill it. So it is going to secrete cytokines and chemical mediators that are going to recruit other immune cells. And it is the immune reaction that causes problems in tuberculosis. So transmission, infected macrophages release cytokines that attract other phagocytic cells, and eventually it forms a tubercle, which is also known as granuloma, that I'll show you later on. So bacilli, these are rods, the mycobacteria, they can spread through local lymph nodes if bacterial replication is not controlled or if the immunity is weak, as in certain cases. Growth continues unchecked until a cell-mediated response develops 2 to 6 weeks later, right? So it is cell-mediated immunity. At this point, it can either advance to active disease or it can become latent. So once the bacteria are inside the alveoli and they have been taken up by the macrophages, depending upon the host factors and depending upon the virulence of the mycobacteria as well, it can become active or latent, right? So mycobacteria, that's the problem. Mycobacteria can divert the normal phagosome pathways and prevent its fusion with lysosomes inside macrophages and continue to survive or even multiply. Now, that's what I'm going to show you now. So, and this is the normal phagosome pathway. This is bacteria, any bacterium. It is taken in by this endosome or phagosome, whatever you want to call it. Both are correct. And this is a lysosome. And you know that the lysosome is full of enzymes, digestive enzyme, hydrolases and proteases. So it fuses. And these enzymes, they destroy the bacteria, right? But this does not happen in case of mycobacteria. If it is a mycobacteria, that I'm going to show you in the next slide. Now, this is a mycobacteria. It is a bacillus. It is a rod, okay? It is taken up, this big yellow cell is the macrophage. So it is taken up by the macrophage and in a phagosome or an endosome, right? And this phagosome will fuse with a lysosome and it will make a phagolysosome, right? As I said, lysosome is full of lysosomal enzymes and it usually destroys the bacteria. But when it is a mycobacterium has got certain mechanisms which do not allow the phagosome to fuse with a lysosome, right? So it will not die. It will just remain inside the phagosome or the endosome, and it will not come in contact with the lysosome. So no enzymes to destroy it. So it will divide, and it might kill the macrophage, and it will be recycled. Many more will be released when the macrophage dies. All right. So it has long been recognized that mycobacteria survive inside the macrophage by interfering with phagosome lysosome fusion. All right. So that is why uh, what mycobacterium does is it does not get digested by the lysosome, and it uh, initiates or it triggers a strong immune response. And it is that immune response, secretion of cytokines and chemical mediators, and that are going to destroy the lung tissue. You know that these um, these neutrophils and macrophages, they secrete proteases and elastases and so many different enzymes that damage the proteins. So that is how the lung gets damaged when the person is infected with macrophages. So this is time for attendance, and I see that 12 people are present over here. So what I will do is, let me check. Um, uh, I will do everyone attendance, right? So please write your names quickly. We have to go fast. This is a long lecture. So you have got only 30 seconds to write your names. So that's the end of attendance, and we will keep going with the lecture. So we are still on pathophysiology. In latent tuberculosis infection, mycobacteria can survive inside macrophages for decades. That's a very long time. And that is how, latent tuberculosis means that the bacteria are alive inside the macrophages or in the body, and people can get a reactivation of the diseases for some reason, maybe declining immunity after decades. This point is important, and we'll come back to this point later on. This allows mycobacterium to spread within the body via the immune system. That is why mycobacteria are commonly found in lymph nodes, right? So macrophages will go out of the site of infection, and they go through the lymphatics into the lymph nodes, and the lymph nodes can also get infected. Okay, that is why we take biopsies of the lymph nodes sometimes for the diagnosis of tuberculosis, although we have got other ways of diagnosing as well. We do not do that commonly, but that is one of the ways that you might utilize. Okay, when bacterial multiplication with bacterial multiplication, the macrophages eventually rupture and die, releasing many bacilli. And that is how the disease spreads. Large number of activated macrophages surround the solid caseous, which means cheese-like, uh, tuberculosis foci. Foci mean that the necrotic area. The macrophages, they are dying, and some of the mycobacteria are also dying. So we have got a mix of dead cells and macrophages, and because the macrophages, sorry, not the macrophages, the mycobacteria, they have got mycolic acid in their cell membrane. So that is why that granuloma from inside, where it is becoming necrotic, has got a cheese-like appearance, which is known as caseous necrosis. All right, so this is a part of cell-mediated immunity, and this figure shows you this is a granuloma. Inside you see all these dead material and caseous necrosis as a result of death of cells uh, and the breakage of their cell membranes and lysis of the cells, okay? And around this is surrounded by a lot of different types of immune cells, which are written over here, and I'll show them to you in the next slide as well. So this is basically delayed type hypersensitivity. It also develops through activation and multiplication of T lymphocytes. So you have got four types of hypersensitivities. Type 1, which is through mast cells and IgE. Type 2 is IgG directed. Type 3 is immune complexes and glomerulonephritis post-streptococcal glomerulonephritis is a good example. But here in tuberculosis, it is CD4 mediated delayed type hypersensitivity. And that is why this is important to understand, because we do this tuberculin skin test and we wait for 48 to 72 hours, okay? So successful containment of Mycobacterium tuberculosis requires activation of subset of CD4 lymphocytes referred to as T helper 1 cells, which activate macrophages through secretion of interferon gamma. So this is recall of your immunology, right? So T1 helper cells, they secrete interferon gamma that is going to attract macrophages. But the thing is that the macrophages cannot kill the mycobacteria in some cases. In some cases, they do kill them, but in other cases, they cannot kill them. And in order to contain them, what the mycobacteria, what the macrophages and other immune cells do is they form a wall around these mycobacteria to prevent them from spreading to other sites or to adjacent areas in the lungs, okay? So what we have is we have these mycobacteria surrounded by immune cells. I think I've shown you over here, yes. You see, so inside you see these a lot of alive mycobacteria. Some of them are dying as well. And around them, you see a lot of different types. Almost every type of immune cell is there. T cell, B cell, neutrophil, natural killer cell, epithelioid macrophage, and apoptotic cells, macrophages, dendritic cells, foam cells, even foam cells are there. So what is happening over here is, because the immune system cannot kill the mycobacteria, they are forming a wall all around them, right? And they are trying to trap them inside. And what happens inside is that some mycobacteria and some macrophages, some immune cells, they are dying. So we get inside, we get cheesy material because of the mycolic acid in the cell membranes of mycobacteria, all right? So this is known as granuloma. It is a granulomatous infection. Right, so these are different types of cells. I'll quickly go through. And, this is what happens clinically, when you do, this is a very advanced case of tuberculosis, a serious case, and you see this in between. This is known as cavitation in tuberculosis. There is some consolidation over here as well. So chest X-ray of a person with advanced tuberculosis, infection in both lungs is marked by white arrowheads, and the formation of cavity is marked by black. So see, this is a typical appearance in advanced cells, but it may not be present in all types of infections. So the specialists, the chest specialists, the pulmonologists, the specialists in tuberculosis infection, they can very quickly recognize from the chest X-rays whether tuberculosis is present or not. This is just a normal X-ray for comparison, okay? Right, so approximately 90% of patients who experience primary disease have no further clinical manifestations other than a positive skin test, either alone or in combination with radiographic evidence of stable granulomas. So 90%, they have mycobacteria inside their lungs, in their alveoli, but they do not go on to develop the signs and symptoms. What will happen is, because the immune system has responded, so they will have a positive skin test that we will look at a little bit later. Tissue necrosis and calcification of the originally infected site and regional lymph nodes may occur, resulting in formation of a radio-dense area, which is known as Gone complex. Now, Gone complex, I'm referring to this thing, I'm informing you about Gone complex because Gone complex sometimes could be infective. It could contain mycobacteria. So whatever the Gone complex is, the important thing to understand is that an area in the lungs and the lymph nodes, they are both involved. That is why we call it a complex. And a Gone complex retains viable bacteria. making them sources of long-term infection. So that is why Gone complex is important. But again, it is the radiologist who will inform us whether the Gone complex is present or not. So 90% will not develop signs and symptoms. 5% of patients, usually children, elderly, or the immunocompromised, experience progressive primary disease at the site of primary infection, which are usually the lower lobes, and dissemination. Dissemination means it can spread to other parts in the body, like the meninges. So the patient can develop tuberculosis, meningitis, often to involvement of upper lobes of the lungs as well, right? So most commonly it is in the lower lobes. It could be there in the upper lobes, and in 5% of the patient, it will become active and spread to other organs. Approximately 10% of patients develop reactivation. Now, reactivation means they had latent tuberculosis, they had bacteria inside their bodies, they did not have signs or symptoms, right? So they never went to the hospital. And at some stage in life, the bacteria starts dividing and the disease is reactivated. Why that happens? Maybe the immunity has gone down or something that we do not know about, perhaps, which arises subsequent to hematogenous spread of the organisms. Hematogenous means through the blood. In the United States, most cases of tuberculosis are believed to result from reactivation. So it recurs, or it is present in those people who have immigrated to USA from other countries like South American countries, or maybe India, China, these Afghanistan, where tuberculosis is more prevalent. So they had tuberculosis in their bodies. 90% they remain symptomless. They did not know, but they had latent tuberculosis. They immigrated to USA, and after maybe 10 years, 20 years, 30 years, the disease reappeared, okay? Occasionally, a massive inoculum of organisms may be introduced into the bloodstream. Okay, that is not very common, okay? And if it goes into the bloodstream, that means it is going to spread everywhere in the body. This is known as miliary tuberculosis. All right, so so this is what we have done: exposure to Mycobacterium tuberculosis bacteria through a contact, who is coughing, right, or talking or whatever, and who is sputum positive for acid-fast bacillus, okay? Because it has got mycolic acid in the cell membrane. So there is a test which is known as Zeal-Nelson that I'll show you later on. So it is positive, okay? It is inhaled by the recipient and it reaches the lungs. 50% of the cases are cleared by the immune system. There is no infection. 45% of the cases, latent infection. So of the 90% that I said that have no signs and symptoms, out of those, about 50% are cleared, okay? They will never get tuberculosis. All of the mycobacteria are dead in their lungs, okay? And 45 latent and 5% will get active disease right from the start, as soon as the bacteria go into their lungs, okay? And disease might spread to other organs: miliary tuberculosis, tuberculous meningitis, spinal tuberculosis, bone tuberculosis. And of these 45% who had latent infection, 10% get a reactivation, and then they can also get these complications. Now, here is a quick review of your bacteriology. Some important points that you must remember about Mycobacterium tuberculosis. For example, it is a gram-positive bacteria. It is an obligate aerobe. It needs oxygen, right? It cannot live without oxygen. Mesophile is also important. It grows best at temperature that is neither too hot and nor too cold, typically between 20 and 45. This is very important. Slow generation time, 15 to 20 hours, right? I hope you remember that E. coli multiplies in 20 minutes. One divides into two in 20 minutes. But here it is 15 to 20 hours. This is clinically important because if you culture mycobacteria, it is going to take a very, very long time, maybe 3 weeks at least, okay? So slow generation time is important to remember, because if you send the sputum, excuse me, or some other sample for culture and sensitivity, that is going to take at least 3 weeks, right? So it is written that it takes 3 to 4 weeks, okay? It is lipid rich cell wall, sorry, I said cell membrane or cell wall. It has got mycolic acid, 50% of dry cell wall weight. So it has got a lot of mycolic acid in the cell wall. So obviously it is gram positive, so it is going to have a thick cell wall. So correction, mycolic acid is in the cell wall. It is responsible for many of the bacterium's characteristic properties, which one of them is acid fastness, okay? Right. So there are some other species, Mycobacterium bovis, Mycobacterium africanus, and BCG is a laboratory-grown strain of Mycobacterium that does not cause disease. This is used for vaccinations in the newborn, okay? So, so this is just an colored electron micrograph. Electron micrograph is usually grayscale or black and white, but this has been artificially colored, and it shows these are mycobacteria and this big macrophages ingesting them, okay? Or it is also known as phagocytosis, if you remember. Right. So this is showing you Zeal-Nelson stain, and because of mycolic acid or whatever that you have studied in your bacteriology, these red rods are mycobacteria, and you can see them with the help of a microscope against a blue background. Right, so risk factors. And what I mean by risk factor, I'll show you the risk factor in the next slide as well. But what this slide is showing you is how much the risk is higher than for people with no risk factors. For example, if a person has got autoimmune deficiency syndrome, he has got 170 times higher risk than than a normal person, okay? If he doesn't have AIDS, but he has HIV infection, then 21 to 34. You know, HIV infection in later stages causes autoimmune deficiency syndrome. So all people with HIV do not have AIDS, okay? When they get AIDS, when fungal diseases start appearing, or when they start getting diseases which are not common at all, then we say that this HIV infected patient might have developed autoimmune deficiency syndrome. So the risk is very, very high. Recent tuberculosis infection in the last 2 years, 15 times higher risk than a normal person. Diabetes, cancer, immunosuppressive therapy, 3 to 16 times higher risk. And smoking also, I don't know exactly how much higher, but these people have got a higher risk, okay? So risk factor, recent emigration or immigration into USA. Emigration means going out, immigration means coming into some countries, right? So as I said, in the USA, it is mostly the immigrants who get a reactivation of the disease. So that's a risk factor. Vitamin D deficiency, immunosuppression, you know, like in HIV, or people who have transplant and they are taking immunosuppressive medications. Smoking, diabetes, elderly, homeless, drug abuse, alcoholism, prisoners because of their conditions, unhygienic conditions, you know, they are all at risk of developing disease, right? Clinical presentation, pulmonary tuberculosis alone is about 50%, lymph nodes alone 30% of cases, other organs. So these statistics, these are estimates, and they might not be very accurate. You might find differences from other sources, okay? And in about 20% of patients, bones, spine, meninges, GIT, these places could be involved. In cases of pulmonary tuberculosis, the symptoms are going to be from the lungs. And extrapulmonary tuberculosis will depend where the tuberculosis is. If it is GIT, the patient will have GI symptoms. If it is bone, maybe he will have bone pains, okay? So in cases of pulmonary tuberculosis, which is the most common type of tuberculosis, the onset of symptoms is gradual. There could be weight loss, particularly in patients who are not treated. Obviously, he will be weak and he will be fatigued quickly. He will have a productive cough. You know, cough is the source of infection for other people, the source of droplets. Fever and night sweats, these are the possible clinical presentation. Extra pulmonary depends upon the organ system involved, and it typically consists of slowly progressive decline in the organ function. Low-grade fever could be there. So all of these are, this is a chronic disease, and obviously the person will have anemia of chronic disease as well. Right. So patients with HIV, they have atypical, even elderly patients have atypical presentation. They are less likely to have a positive skin test. Okay. Frank hemoptysis, Hussein has written frank hemoptysis. It is possible, right? Frank hemoptysis means a lot of blood. Hemoptysis basically means 200 ml of blood in a day, okay, which is a lot of bleeding. That is not very common, but blood stained sputum is more common in tuberculosis, okay? Right. So these people, because they have poor immunity, so they are less likely to have positive skin test or immune response. You know, fever is because of certain cytokines or cavitary lesions. As I said, it is the immune system that is destroying the lungs because of the proteases and the enzymes that these immune cells release, right? So those who have got no immunity, they will have less damage to their lungs. But on the other hand, they will not be able to contain the disease and the disease will spread in the body, okay? Right, HIV patients have higher incidence of extrapulmonary tuberculosis, as I said. They are more likely to present with progressive disease because it is spreading. The immune system is not able to restrain it at a particular site. Right. In the elderly, tuberculosis is easily confused with other lung diseases. You know, elderly people, we have done pneumonia last time, and it came in the differential diagnosis of pneumonia as well, community acquired pneumonia. Elderly patients are less likely to present with positive skin tests, just like HIV patients, because their immunity is also weak. And again, fevers over here as well, but they will have night sweats and positive sputum samples, or they can get hemoptysis, right? By definition, hemoptysis is a lot of bleeding from the lungs coming from the lungs. It has to be differentiated from heme at emesis that you must have done in pathophysiology. But more common is spitting little amounts of blood with sputum. Right. So clinical presentation, the two important things over here is this weight loss, fatigue, productive cough, fever, and night sweats that I've shown you in previous slide. And the other important test in laboratory examination or investigation is lymphocyte predominance in WBC count. All right. So these are the two important things that you have to remember from this slide. Again, this shows cavitation in a 47-year-old man with chronic cough and poorly controlled diabetes mellitus, which is a risk factor for development of tuberculosis. Okay, and this shows you a tuberculous spine. You know, these are normal vertebrae, normal vertebra, but this one is collapsed because he had spinal tuberculosis. So this is one example of extrapulmonary tuberculosis. So diagnosis of tuberculosis is based on systemic symptoms that I've shown you previously. Risk groups. So when you are diagnosing tuberculosis, you will take into account all these things. You take a detailed history and you do physical examination, so you know all these things, right? So we take into account the risk groups as well, like the immigrants or HIV, alcoholics, drug users, whatever I've shown you in the previous slides. Localizing symptoms to that specific organs, most commonly it is pulmonary, and history of exposure. So systemic symptoms I've given you over here, risk groups I've already given you, localizing symptoms depending upon the organ involved and history of exposure. So we don't need to go into any more details over here. Screening for tuberculosis is done with tuberculin skin test, which is not, you must remember that if it is positive, it does not mean tuberculosis, all right? And I'm sure you already know this thing. So tuberculin skin test, which uses purified protein derivatives, it is known as PPD. Populations most likely to benefit from skin testing are HIV positive patients. But remember, and I'll show you this later on as well, that in HIV positive patients, skin test might be negative sometimes, or the reaction is very weak, okay? We measure the induration that I'll show you in the later slides. Patients with organ transplants receiving immunosuppressive drugs, so again, their skin reaction is going to be weak. Recent contacts of tuberculosis cases, chest X-ray showing changes consistent with tuberculosis, and this is a tuberculin purified protein derivative, PPD. It is known 5 tuberculin units, which is written over here. We get them from different manufacturers, okay? And this is the national drug code, which means it is from the USA. And this is the skin test. So we give this PPD intradermally, not subcutaneously. We give it just beneath the epidermis, okay? And we should get a sort of a bubble like this, a blister sort of things. So here it is, this is epidermis, and we give it just below the epidermis. So we get this sort of blister above wherever we have injected this PPD, okay? And after 48 to 72 hours, we get the reaction, you see. Induration means there will be a hard area, and redness means red area, right? So there are two things. Usually we look at the reddish, or the hard area, the induration. So the test is read 48 to 78 hours after injection by measuring the diameter of the zone of induration, hard area, right? So this is all. And now we measure it with a scale, and we see how many millimeters it is, okay? Some patients may exhibit a positive test after an initial negative test, which is known as the booster effect. See, you give a test and there is very weak reaction or no reaction. So you try it again after 1 week and you get a strong reaction. That is what booster effect is. Right. So this slide is important. Positive test defined by the diameter of induration. We have got 2 or 3 more minutes before we take a break. So this is the last slide that we will do before the break, okay? So positive test is defined by the diameter of the induration, the hard area. So you see we are measuring in millimeters, and this is about 15 mm, which is a strong reaction. Now, as I said, in immunocompromised elderly people, the reaction is weak. So just 5 mm of induration is sufficient for diagnosis of tuberculosis, right? We might have to do other tests that I'll show you later on. 10 mm for high-risk groups that I've shown you, the immigrants, alcoholics, and whatnot, okay? 15 mm for low-risk groups, normal people, okay? 90% with greater than 10 mm and virtually all with greater than 15 mm are infected, okay? Induration less than 10 mm may be cross-reaction with other mycobacterial species or prior vaccination. So if, if it is more than, if the patient is normal and the reaction is there, but it is less than 10 mm, then obviously we'll do further investigations. And if it is more than 10 mm or 15 mm or more, then we are pretty sure, but still we will do confirmatory tests, okay? It takes 3 to 9 weeks after infection for tuberculin test to be positive. It is a cell-mediated immunity, so the immune system must respond, and the immune system takes 3 to 9 weeks to respond in cases of cell-mediated, and the test has certain limitations. So we'll quickly do this slide and then we'll take a break. BCG vaccination in Saudi Arabia is mandatory, and it is not recommended during pregnancy. It is not administered to the following individuals which are immunocompromised due to HIV infection. Remember, it is attenuated bacterium. It is BCG. It is a bacterium that has been produced in the lab, attenuated. It does not cause infection, but these people are immunocompromised. They have no immune system at all. Congenital immunodeficiency, malignancy, and immunosuppressive drugs. So most what we are saying is the immunity is very weak. Okay, so in those cases, we do not give vaccination. So now we take a break and come back after 10 minutes and remind me to start the recording once again. All right. All right, so I hope everyone is back from the break, and we will start once again
Yes,
the lecture.
doctor, do you start the record?
I have started the recording. Thanks
Yeah,
for
thank you.
reminding me anyway, because many times I forget. Okay, so you should always remind me. Right. So as I said, it is mandatory in Saudi for the babies when they are born, and in many countries, this BCG vaccination is mandatory, and it's given to babies in the first week, right? Okay, or after the first week. I hope I'm right. Right. So again, this is just to show you that 16 students in Indiana, that's in the USA, were accidentally injected with insulin because they are using an insulin needle. It has got a very small and 27 gauge syringe, so it's good for intradermal injection, although insulin is given subcutaneously. Right. So this could happen. Now, confirmatory diagnosis, it is after a clinical suspicion. For example, if the reaction to skin test is very strong, then for pulmonary tuberculosis, you will take 3 morning sputa samples taken on consecutive days for microscopy and culture. And you'll stain them for acid-fast bacilli and you'll send them for culture. And the culture result will come back after 3 to 4 weeks, okay? For extra pulmonary tuberculosis, you can take biopsies. For example, I mentioned that sometimes you take biopsies of the lymph nodes, or you can take an aspiration biopsy. Because it's not in the lungs, so sputum cultures may not be positive in those cases. So the lab test is staining for acid-fast bacilli. Culture, they grow in 3 to 4 weeks, and you can do PCR as well. And you've got interferon gamma release assay as well. As I said that these T helper cells, they release interferon that activate the macrophages, right? So measures immune response to tuberculous proteins in the whole blood. So what we do is that we take the blood samples, which contains the white blood cells from the patient, and we incubate that sample with a mixture of synthetic peptides simulating 2 antigenic properties of mycobacteria, of proteins secreted by mycobacteria. If the person is infected with Mycobacterium tuberculosis, white blood cells recognize antigens and release interferon gamma, okay? Because their white cells are conditioned. So we are taking it from the patient. If the white cells are not conditioned, then they will not secrete interferon gamma. Results are based on the amount of interferon gamma released. 2 types are available, quantiferon and T-spot, okay? Results you can get in less than 24 hours. and it is not influenced by prior BCG vaccine like the skin test, which will be positive in cases of prior vaccination as well. Now, goals. Now we go on to the treatment. The goals of treatment is obviously quick diagnosis, rapid identification of the cases, isolation of the patients to prevent the spread of the disease and to reduce transmission of the disease, collection of samples like sputum and send them for cultures and for AFP. We want prompt resolution of signs and symptoms. We want the patient to achieve a non-infectious state so that it is not transmitted to other people, and when he becomes non-infectious, then we no longer want to isolate him. Adherence to treatment regimen is very important because it is a long treatment, 6 months or 9 months or even longer, depending whether the bacteria are susceptible or resistant. And we want cure. Our goal of treatment, one of the goals or the ultimate goal is to cure the patient of the disease, okay? Right. So the general principles of tuberculosis treatment is a minimum of 2 drugs, and routinely we use 4 drugs. They must be used simultaneously. We have got 2 phases of treatment that I'll show you. We have got an intensive phase and a continuous phase. Our drug treatment is continued for at least 6 months. For multiple drug-resistant, treatment must be continued for 18 to 24 months, and maybe in some cases even more than that. Measures to assure adherence, such as directly observed therapy or video observed therapy, which is not difficult these days. So what we want to see is that the patient is actually taking the drugs. So he puts the drug in his mouth and takes it with water or whatever. We must observe that. Patients with active disease should be isolated to prevent spread. Okay, that we have already said in the previous slide. Now, the public health departments are also involved. We have to inform the relevant health officer or whatever of every case of tuberculosis. Now, public health departments will take measures to prevent the spread of disease, and they will investigate all the contacts. Like I'll show you, some contacts have to be treated as well. Debilitated patients may require therapy for other medical conditions as well. So usually, if it is an old person, old people have got so many other diseases. And, if the person is a drug addict, he's abusing some substance, HIV infected patients and patients on nutritional support, right? So surgery may be needed. For example, in cases of destroyed lung tissue, you might have to remove that, or when it spreads to the bones, so you have to do surgery. But our main objective is to know the pharmacologic treatment for tuberculosis. So this is the drug list. These are the first-line agents: isoniazid, rifampin, pyrazinamide, and ethambutol. And then we have got these second-line drugs, which include these amikacin, aminoglycoside, and bedaquiline. This is a relatively newer drug. But among this, the pretomanid is a new drug, okay? And we sometimes combine this with fluoroquinolones and aminoglycosides as well. So we will discuss the treatment of latent infection and active disease, multiple drug-resistant tuberculosis. We'll not go into a lot of details. We'll discuss tuberculous meningitis. The good thing about these drugs is that the tuberculous drugs like rifampin, they cross the blood-brain barrier. So special populations like children, pregnant women, some of these we will discuss and some of these we will not discuss, okay? So latent tuberculosis means a patient is infected with Mycobacterium tuberculosis, but the bacteria are not dividing. They are in a dormant state. They have been contained by the immune system, by the macrophages. They have been walled off. We call this walling off, okay, walled off. A wall has been formed all around them. Chemoprophylaxis should be initiated in latent tuberculosis infection. LTBI stands for latent TB infection. And we do that for to reduce the risk of progression. Okay, so this is a website which will give you more details of treatment. If you want, you can refer to this website. So who should be treated? HIV patients, the immigrants from high prevalence countries, okay? And then close contacts of the patients infected with tuberculosis, drug users, laboratory persons who are culturing the bacteria or who are testing the sputa, then children under 4 years of age or adolescents exposed to high risk, not patients. You know, these children, even if they are exposed to high risk categories, they may or may not have tuberculosis. Even then, you have to give them treatment, okay? Immunosuppressed persons and those who have got chest x-rays that are not normal. So in the next 3 or 4 slides, I'll repeat the same thing, which is that the CDC recommends 12-week isoniazid rifampicin regime. That is one option. The other option is 9 months of daily isoniazid 300 milligrams. Healthy patients 12 years or older who have the following risk factors like recent exposure, conversion from negative to positive, all right? Radiographic evidence of healed tuberculosis, and their interferon gamma release assay is positive, their tuberculin test is positive, right? And they have got this history of exposure and seroconversion, then we give them this treatment. Now we have got many options. We have isoniazid, we have rifampicin, and we have isoniazid plus rifampicin, right? So many options. We can give isoniazid for 6 months, 300 milligram, 180 doses. So the number of doses you have to know, because the number of doses are important. They are even more important than the duration for which you give the treatment, right? I hope this point is clear. You have to memorize the number of doses. So isoniazid, we can give 300 milligram daily, or we can give 900 milligram twice weekly for a total of 52 doses, right? Or we can give for 9 months 300 milligram daily, 270 doses, or 900 milligram twice weekly, but 76 doses. Here we have got 52 doses, okay, twice weekly. So this is 26 weeks. 26 weeks is about 6 months, okay? Rifampicin 4 months, for 4 months, which is 600 milligram daily. So 4 months is equal to 120 days. Or this is for 3 months, which is, this is once weekly. All right, this combination is once weekly, 900 milligram plus 900 milligram. So once weekly, 12 weeks is equal to 3 months, right? So this you have to memorize. Again, a repetition of the same thing. 300 milligram for 9 months for non-compliant patients. Isoniazid 15 milligram per kilogram to a maximum of 900 milligram twice weekly if they are non-compliant. But for all these cases, it's written with observation, directly observed therapy. You must watch the patient taking the drug, putting it into his or her mouth, okay? Or rifampicin 600 milligram for 4 months, rifabutin 300 milligram daily may be substituted for rifampicin. This RAF is for rifampicin. All right, that's the abbreviation. Pregnant women, alcoholics, patients with poor diets who are treated with INH should receive pyridoxine. Now remember the dose of pyridoxine, it is 10 to 50 milligram daily for these people. But if we are giving it to prevent peripheral neuropathies, okay? But if peripheral neuropathy is present, here we are trying to prevent it. It's not present. If it is present, then we have to increase the dose, and that dose I'll show you in one of the slides later on, right? So same thing I've repeated. in 3 slides. 9 months, 300 milligram, 270 doses, 900 milligram twice weekly, 76 doses. Okay. Areas with multi-drug resistant isolates, 2 drugs with activity against the isolate for 6 to 12 months. So that's for multi-drug resistant cases, and we are talking of latent tuberculosis. Now we go on to the active disease. Again, we have to look at the susceptibility data, whether the organism or the mycobacterium is susceptible or resistant, and the results will come from the culture, and the culture takes 3 to 4 weeks. Okay. If susceptibility data are not available, then we look at the resistance pattern in that specific area from where the patient has come, right? If he has come from India, we have to look at that area in India because he got the bacterium from there. Okay. If the patient is being evaluated for retreatment, then we look at the previous treatment, right? Maybe he has got resistance. That is why we could not eliminate the bacteria. Right. So the general principles are we give an intensive phase in which we give 4 drugs. That is for 2 months. This is for susceptible people or drug susceptible bacteria. And continuation phase in which we give only 2 drugs, rifampin and INH, isoniazid. We give this for 4 months. So the total treatment is 6 months. Then, but this is a combination therapy, but we exclude some people like see pulmonary tuberculosis with positive culture after 2 months. We give treatments for 2 months and the culture is still positive. It should have become negative, but it is still positive. Now that indicates the possibility of drug resistance. Okay. So I hope you got this point. Bone and joint involvement. So that means we have to do something. Sometimes you do surgery. Sometimes we give drugs for a longer period of time. CNS involvement. Patients with HIV who are not receiving antiretroviral therapy. When the patients are receiving antiretroviral therapy, you have to look for drug interaction. You know that rifampin is a very strong inducer of CYP450 system, right? The enzymes, I'm sure you all remember that. So drug susceptible is standard treatment. Once again, intensive phase, INH, rifampin, pyrazinamide, ethambutol for 2 months. Rifampin, you have to be careful. The color of the secretions change, orange to red, even the tears. So those who are wearing contact lenses, their lenses could get stained with those colored secretion or tears. Okay. Then continuation phase is both isoniazid and rifampin for 4 months, and we are talking of drug susceptible organisms. Caution: send samples for culture and culture and sensitivity, or you can call that susceptibility as well. Before initiating, that we do in all cases, in all diseases, we take the sample, and before initiating the antibiotics, we send them for culture. Okay. Now, these slides you have to study, what we are showing is dosage forms, recommended doses, adverse reactions, additional comments, special counseling points, if any, many of you are doing patient counseling as well. So this is a good slide. We will decide later on whether we will include that in the examination or what will we do with these 2 slides. Okay, but these are good slides. Okay, and most of it you have done in your pharmacology as well, so you must know it, right? So intensive phase, I don't have to tell you again and again, it is rifampin and isoniazid, and we have got daily dosing, we have got thrice weekly intermittent dosing, and we have got twice weekly dosing. Okay. So which patients do we give thrice weekly dosing? Those who have got low risk of relapse. The best is daily dosing. But if the patient is not compliant, is not adhering to therapy, or with these characteristics like low risk of relapse. He's multi-drug susceptible. The mycobacterium, MTB stands for Mycobacterium tuberculosis. There are no cavitary lesions on X-ray. The smear is negative, okay? The patient is HIV negative, then we can go on to 3 weeks treatment or twice weekly treatment as well. But for twice weekly, there is just one difference. The patient has completed initial 2 weeks of daily therapy, right? So after that, with these characteristics, same low risk of relapse, drug susceptible organism, no problems with the chest x-rays or smear is negative, no HIV, then we can go to 3 weeks or 2 weeks treatment, all right? Isoniazid and rifampin are included in the continuation phase. So the intensive phase, isoniazid, rifampin, pyrazinamide, and ethambutol, 4 drugs. Continuation phase, only isoniazid and rifampin, and we are still talking of patients or the bacteria that are drug susceptible. Daily, thrice weekly, daily is the best. Thrice weekly you can give to the patients. Thrice weekly dosing is preferred if intermittent dosing is necessary for some reason, okay? Now, again, I've given you a table, patients with HIV and patients without HIV, right? And the regimen and the treatment, okay? Optional, less efficacy. This is the recommended, and this one has got less efficacy. So you can, it's not a big table. I hope it's not difficult to memorize these tables. You don't even have to memorize. Just read it and you'll see that it just gives the details of what we have already done in the previous slides. Right. Isoniazid, now we go into a little bit of details of the drugs, the pharmacology, the mechanism of action. It is not exactly known, but likely it inhibits the synthesis of mycolic acid, resulting in disruption of bacterial cell wall, okay? So once again, I will remind you that mycolic acid is in cell wall. Initially, I said it is in cell membrane, but it is a gram-positive organism. It has got a thick cell wall, so mycolic acid is present in the cell wall of the bacterium. It is bacteriostatic in resting bacilli and bactericidal in dividing bacteria, okay? Practical consideration, if there is isoniazid does cause peripheral neuropathy, so pyridoxine 25 to 50 milligram. In pregnant, diabetic, alcoholics, and malnourished patients or advanced stage, chronic kidney disease, in all these cases, we will give preventive pyridoxine, vitamin B6. Pyridoxine 100 milligram if peripheral neuropathy is present. Here, we are trying to prevent it. Here, it is present, okay? Watch out for hypersensitivity and lupus-like syndrome, right? So then we go on to isoniazid. This is also isoniazid. LFTs, because it is hepatotoxic, it's there in the slide, it is liver toxic. Monitor for signs and symptoms, right? Look at the normal levels of ALT and AST and look how much they are increased, right? Those are the red flags. INH should be discontinued if the levels exceed 3 to 5 times of the upper limit of the normal, 35 or 40 milligram, whatever the normal level is. If it goes 3 to 5 times, 100, 150, 200, then you have to discontinue. That means the liver is getting damaged. It can be used as monotherapy. We have already seen that for latent tuberculosis. It could be given to the contacts as well. Pharmacogenomics, we have got slow acetylators, we have got rapid acetylators. So rapid acetylators metabolize it more quickly, but we do not routinely do this genetic test. I'm not sure if the hospitals do it or not. Maybe some hospitals do it. But be careful. Keep in mind that It could be metabolized faster or slower depending upon the enzymes or genetic makeup of the individual. So it says that genetic testing is not performed routinely, okay? But I'm sure you remember the slow acetylators and the rapid acetylators. Right. Now we go on to rifamycins. Rifamycins has got rifampin, rifampicin, rifabutin, rifapentin, rifaximin. Rifaximin is belongs to this group, but it is not used for tuberculosis. It is not absorbed. It is used for GI infections like vancomycin or neomycin. Right. It could be used for C. difficile, or it could be used for traveler's diarrhea, but it is not used for tuberculosis, okay? Mechanism of action, it is protein synthesis inhibitors. It inhibits RNA polymerase, okay? Remember, it inhibits RNA polymerase. We need that for protein synthesis, okay? It is written DNA-dependent RNA polymerase, which means RNA polymerase, okay? So rifamycin should not be used as monotherapy for active tuberculosis. Okay, for latent, it is used as monotherapy for 4 months, if you remember. Again, you have to take baseline liver function tests and complete blood count. Rifaximin is not used for mycobacterial diseases, as I've already mentioned. It is not absorbed from the GIT, and it is used for GI infections. It is even used for irritable bowel syndrome, right? So all these drugs, I mean, especially rifampin is a potent inhibitor of cytochrome P450. Now we have a problem over here, and the problem is that in pregnancy, we advise the women, not in pregnancy, if the woman is in the reproductive age, we ask her not to get pregnant. And not to get pregnant if she is sexually active means she has to use contraceptives. And oral contraceptives are metabolized in the liver, and rifampin is a potent inducer of P450 system. So what I'm trying to say is, if the woman is taking oral contraceptives, then it could, and she's taking rifampin as well, it could result um, in the failure of these drug. Okay, just let me off the clock. We call that contraceptive failure, right? Just slipped my mind. So because it is a potent cytochrome P450 inducer, it is going to decrease the blood levels of warfarin, contraceptives, antifungals, corticosteroids, tacrolimus, and more importantly, protease inhibitors. All right, because many people that have HIV also have tuberculosis, so sometimes we have to give a combination. All right, right. Rifabutin, it is generally reserved for patients who are receiving any medication having unacceptable interaction with rifampin, for example, HIV patients taking protease inhibitors, still with significant number of drug interactions, but much less than rifampin. Okay, so alternative to rifampin still has action inducing effects on enzymes, liver enzymes, but better than rifampin. Okay. For patients on non-nucleoside reverse transcriptase inhibitors or protease inhibitors, there is a drug interaction, so you have to refer to these guidelines, okay? And monitoring parameters are same as rifampin, again, liver function, right, and CBC as well. Rifapentin, this is a second-line drug given once weekly. It shares susceptibility with rifampin and rifabutin. So same group, just very brief descriptions of different drugs, okay? Pyrazinamide, it is bactericidal in acidic environment, and when mycobacterium is present, the environment is acidic. So it is a good thing. It will work very well over there. Okay, particularly useful during initial phase of treatment. That is why we give 4 drugs in the initial phase, and it is effective against dormant or semi-dormant intracellular bacilli. Good thing for initial phases. Uh, it may play an important role in preventing relapses. It may cause hyperuricemia, but it does not precipitate gout, but we have to keep this thing in mind. It can cause arthralgia, hepatotoxicity. So, all drugs are hepatotoxic. Not all, maybe the last one, which is ethambutol, it has got a different adverse effect, which is on the eyes and which is color blindness, if you remember. So mechanism of action diffuses into actively growing bacilli, inhibits synthesis of greater than one metabolite and leading to cell death, right? Uh, Used primarily to prevent the emergence of rifampin resistance when primary resistance to INH may be present. So, both these drugs, ethambutol and pyrazinamide, are more active in the initial phases of the disease. That is why we are including them in the initial phase of the treatment for the first 2 months, which is known as the intensive phase. Practical consideration: optic neuritis, color blindness. So in all cases, what you have to do, you have to take baseline test. You have to take baseline hepatic enzymes, baseline blood test, okay? CBC. You have to take this, you have to do baseline eye examination as well. Okay, so that is what you have to keep in mind. Now, treatment interruptions, these are the tables. This is for your self-study. We will decide later on what to include in the examination and what not to include. We are definitely going to include some tables, but we will decide that later on. Directly observed therapy, I've already explained to you. You can do it through video. You can call the patient to the clinic and tell him to take the drug in front of you, ingest the drug in front of you, or the nurse or the pharmacist or whatever. So this is directly observed patient. Isolation of the patient until the patient has become non-infectious. What is non-infectious? 3 negative AFP smears at least 24 hours apart. So 3 days. Take his sputum sample or swab or whatever. If he is AFP negative for 3 consecutive days, he is non-infectious and he does not need isolation any longer. Right. So this is examples of priority situations for the use of directly observed therapy. Uh, Positive sputum and delayed culture conversion. Culture conversion means culture becomes negative. Okay. And if there is treatment failure, relapse, drug resistance, homelessness, lots of things, intermittent dosing. Remember, twice weekly, thrice weekly, we have to use directly observed therapy. So a lot of cases that you can just think of, okay? Children, adolescents, mental or disabled people, um, residents in correctional facilities, previous treatment, or latent tuberculosis. All right, in all cases, these are the indications for directly observed therapy. Right. So again, let me remind you that it is the total number of doses taken that is more important than the duration of the treatment. So that is why in one of the previous slides, I said you should know the number of doses that the patient needs to take, whether it is daily dose or twice weekly or thrice weekly, 270 doses or 52 doses or 76 doses. You have to remember that. Clinical experience suggests patients managed by directly observed therapy administered 5 days per week is equally good in success rate for 7 days, right? So 5 days per week is as good as 7 days per week. Okay, so another important point that you may want to remember: daily therapy may be interpreted to mean directly observed therapy given 5 days, because 5 days is as good as 7 days. So you can do directly observed therapy for 5 days as well. In which patients? In these patients. All right. Okay. Now, this is the resistant pattern in the USA. Nothing much about it. This is resistance to isoniazid, and this is multi-drug resistant tuberculosis, right? So multi-drug resistant tuberculosis, very low, less than about, you see, 2.5, and now it is around 1.5%. Isoniazid, 6 to 7 or 8% resistance, okay? This slide I've shown you just to explain to you what polydrug resistance means, right? Percentage is given. This is not for the exam, okay? But the next slide, monoresistance means resistance to one first-line drug. Polyresistance means resistance to more than one first-line antituberculous drug. Multi-drug resistance means resistance to at least both isoniazid and rifampin. So that's, here it is one drug, uh, and more than one first-line antituberculous drug, which includes pyrazinamide and ethambutol. Extensive drug resistance to any fluoroquinolones, which are second-line drugs, and at least one of three second-line drugs like caprimycin, kanamycin, amikacin. Then rifampicin resistance, that's not difficult to understand. It is just rifampicin resistance. So this is just to let you know what different types of terms are used for resistance. And that is all. It finished pretty rapidly, right? So I'm sure you're happy that the lecture is over. If you have any questions, you can ask me. If you have any comments, you can say that now. All right. Should we take attendance, or is Myrna there? Myrna, sorry. So that's all. If you have no questions, then thank you very much for attending this lecture, and inshallah, we will meet next time, right?
Thank you.
You are welcome.